Good afternoon. My name is Dr. Eric Twaring. I'm the Senior Vice President for the American College of Veterinary Preventive Medicine, and I would like to welcome you to the webinar this afternoon. Today's webinar is sponsored by the ACVPM, the American Association of Food Safety and Public Health Veterinarians, the National Association of Federal Veterinarians, U.S. Animal Health Association, and the National Association of State Public Health Veterinarians. So it's my pleasure today to introduce our guest speaker, Dr. Kimberly Woodruff. Dr. Woodruff received her DVM from Mississippi State University in 2008 and joined the faculty as a veterinary epidemiologist in the Mississippi State College of Veterinary Medicine in 2012 after completing an internship and residency. Dr. Woodruff is currently the course leader for the first-year epidemiology course, the third-year population medicine clinical rotation, and co-leader of the Mississippi State University College of Veterinary Medicine ACVPM approved residency program, population medicine residency. Dr. Woodruff is a diplomate of the American College of Veterinary Preventive Medicine and also a diplomate of the ACVPM's epidemiology specialty, where she serves as the secretary. I will turn it over now to Dr. Kimberly Woodruff.
Thank you. And thank you for having me. I cannot see any of you, but I can see me. So that makes me feel like I'm talking to myself. So I'm going to stop my video for the duration of this talk. And sure, I'll be happy to take questions at the end of this. Okay, let's get started. Let's start with a scenario. I will say that some of you may have seen this presentation. I did it, we were just talking in 2021, which seems a lot more recent than it actually is. But somebody asked for that again, so I apologize if this is the same one that you've seen. Hopefully it will be a good review, and maybe you'll catch some things that we didn't talk about the first time around. So, all right, we have a client who is a 10-year-old little girl. She has just adopted her kitten from a shelter. She's very, very excited. And she and her mom bring you her 6-month-old kitten. It's healthy and bouncing around, and you perform a physical exam and you don't find any problems. The cat is apparently healthy. And so in the conversation, they mentioned that it was not tested for FELV or FIV at the shelter. And so you talked to them about that, and they agreed to test her for both FELV and FIV. And so you do that, and the test for FELV comes back positive. So now the questions are, what do you do? What do you recommend to your clients? What do you recommend to a 10-year-old little girl who's very excited about her kitten? And then do you fault the shelter for letting this happen to you? Do you fault them for not testing all of their cats for FELV and FIV? And so hopefully we're going to be able to answer those questions in the duration of our time together. We know that we have a lot of diagnostic tests, right? From physical exams to who knows what, they're just, we have many diagnostic tests just at our fingertips. The problem comes when those tests are incorrect, when we have a false positive or a false negative, and then we end up with animals that are euthanized or culled when they don't need to be, or the spread of disease because we falsely classify a herd or an animal as disease negative when actually they're disease positive. It might result in treatment delays or financial resources or manpower resources used on unneeded treatments, or animals that have to endure an unneeded treatment. And then the misclassification of a population, which could have a lot of consequences. So there's a lot of things that we need once our results are in. We need to think about the situation, right? We need some clinical judgment about the pretest probability, which is how probable do we think this disease was before we even started testing. And that will involve things like our physical exam, the clinical signs that we see, what we know about the disease in our area. We may have a cat that looks healthy, but we may get a history that says half of the litter died from some other disease. And so even though the cat looks healthy, that might raise our suspicion of disease a little bit. So we take all of these things into consideration, And these things help us decide, is it worth running a test? What do we think the test is going to be? Is it going to be positive or negative? What are we expecting? And then if we get something we're not expecting, what are we going to do with it? So we are going to first talk about diagnostic test performance. And we are going to be staring at this 2x2 table. I tell my students that the 2x2 table is going to be their best friend or their worst enemy in epidemiology. And so we're going to assume that for the rest of this hour too. We're going to start with sensitivity and specificity. When I describe sensitivity, specificity, positive and negative predictive value to my students, I tell them that it's hard to remember what plays into which category, but I tell them that this is the probability of you being right about your test. What you have to remember is the population that you're interested in, and then the probability that you're right. So for sensitivity, you are only interested in diseased animals. That is whether or not they test positive or negative. If they have the disease, they're going to go into your calculations for sensitivity. So for sensitivity, we're only interested in the disease population, and our sensitivity is a probability that we're going to get that right, that we're going to get a positive test for an animal that's diseased. On the flip side, specificity only deals with animals that do not have the disease that we're interested in. They can have other diseases, but they don't have the disease that we're looking at. And so of all the diseased animals, what's the probability that we're going to get it right? What's the probability that we're going to find all the ones that are not diseased and not mark them as false positive? So we have some formulas for that. To figure out the sensitivity of a test, or the probability that an animal that tests positive, for an animal to test positive if they have the disease, we're going to look at the tests that were positive, and we are going to divide that by all of the diseased animals. Now, some of this assumes that we know everything, we're omnipotent, and we don't always have that information, and there's other formulas to figure that out. But for today, we're going to just say we know everything. And so we know the animals that are actually diseased. So we know who's the true positive, and we're going to divide the true positive by all of those that tested that were positive or negative, if they had the disease. Again, on the flip side, specificity is a probability for an animal to test negative if they don't have the disease. We're only interested in non-diseased animals. Our numerator is our true negatives, and our denominator is everybody that doesn't have the disease. Again, information that we don't always have at our fingertips, but today we do, because I get to lead this and I say we do. So let's look at an example. So we have a population of 1,000 animals, and we'll say that 100 animals in our population have the disease. So 900 of those animals don't have the disease. So if we wanted to figure out the sensitivity, we would say 80 animals that tested positive that have the disease divided by all of the animals that have the disease. And so we would get a sensitivity of 80%. So of all the animals that have the disease, we have correctly identified 80% of those animals. For specificity, we look at all of the animals that do not have the disease. We're interested in those that tested negative as our numerator, our true negatives, and we're going to divide that by all of those that don't have the disease. So divided by 900. And so this test has a specificity of 89%. The next thing we need to think about is what's the probability that the test reflects the true disease status of the animal. And so that is post-test probability, either positive predictive value or negative predictive value. For positive predictive value, well, for both predictive values, we are interested in our test results. So for positive predictive value, we are only interested in those animals that test positive. I'm sorry, those tests that are positive. and we look at the true positives divided by all of the animals that tested positive. This is a much more complicated formula when you don't have the information. If we have the information that I'm saying that we have today, which is we know everything and all the numbers that go in these squares, we can use this formula. If we don't, we think about the prevalence of the disease, and we use test sensitivity and test specificity, and we can figure out what our positive predictive value is. The same thing for negative predictive value. We're interested in all of the tests that are negative, and we want to know how many of those tests, of all the tests that were negative, how many truly identified an animal that doesn't have the disease. So I'm sorry, an animal that doesn't have the disease. So true negative divided by all of the tests that were negative. Again, we have a very complicated formula if we are not all knowing. When we know something about the test and something about the prevalence of the disease. All right, so let's try positive predictive value. We're going to do this positive predictive value a couple of times, because what I want you to understand is how the prevalence of the disease affects our positive or negative predictive value. One thing, let's go back here to sensitivity and specificity. This always gets my students, and so I want to make sure prevalence affects positive and negative predictive value. It doesn't affect sensitivity and specificity. That is because for sensitivity, we're only worried about animals that have the disease, right? And so the prevalence of animals, when we are calculating sensitivity, prevalence of animals that have the disease, 100%, because that's all we're interested in. And for specificity, we're only interested in them if they don't have the disease, and so prevalence is always 0. So my students get confused about which one of those involves prevalence or takes into account prevalence, and so that's a pretty easy way, hopefully, to remember that. Okay, so let's figure out this positive predictive value. We're going to say that the prevalence of this disease that we're thinking about right now is 1% in our population. So out of 1,000 animals, 1% of that is 10. So 10 animals have the disease. This is our test performance up here, our sensitivity of 80% and our specificity of 89%. So we can fill out the rest of this table now, right? If we have 10 animals, we know that we're going to correctly identify 8 of them as diseased. And so we're going to miss 2. We're going to have 2 animals that were diseased that test negative. And so, I'm sorry. And then our specificity is 89%. And if we have 10 animals that have the disease, then we have 990 that don't have the disease. And 89% of that is 881. So we correctly identify 881 animals that are free of the disease. All right, so prevalence of 1%. Now we're going to figure out the positive predictive value. We have 8 tests that are negative, that are positive, that are correct, but we have 117 total positive tests. So 8 correct tests divided by 117 total positive tests is 6%, which is not a very high positive predictive value, right? So if you are testing a disease and you know that it has a 1% prevalence and you get a positive test, it's not really going to change what you think a whole lot. You are 6% more likely now to have that test, to have that disease than you were before you tested. You're 6%. You have identified 6% of correctly positive tests. On the other hand, in a 1% prevalence population, we are going to correctly identify 881 animals as not having the disease with our specificity of 89%, but we have 883 negative tests altogether. So 881 divided by 883 is 99.7, almost 100%, not quite, but almost. So we've done a pretty good job ruling out the disease, right? And if we know that the prevalence of a disease is 1% in our area, then we're going to be pretty likely to believe a negative test. We're not going to be surprised that it's negative, so we're going to believe that. Now, all of this changes a little bit if you have an animal in front of you that's sick. So we are thinking that there's a low prevalence of disease in our area. And we are thinking that we have a healthy cat, or like the FELV situation that we're talking about. If that cat came into us really sick, lethargic, and some of the signs, then all this stuff goes out the window and you think about it again with your clinical judgment. Okay, now we're moving into a prevalence of disease of 15% in our population. So we have the same 1,000 animals, and now 15% of them are sick, or 150 of them. We have the same sensitivity and specificity. We are using the same test. The only thing that's changed here is our prevalence. So of 150 truly diseased animals with a sensitivity of 80%, we're going to identify 120 correctly positive animals, and we're going to miss 30 that are sick, but they're going to test negative. For our specificity, we have 850 animals that don't have the disease, and we're going to identify 757 of those correctly. We're going to say they don't have the disease, and that's going to be true. And then there are going to be 93 that, for whatever reason, we say we know that they don't have the disease, but they're going to test positive. So we're going to get 93 false positives. Okay, so let's work out the positive and negative predictive value for this situation. So we have 213 total positive tests. 120 of those are true. So we're going to divide 120 by 213, and that gives us a 56% positive predictive value. So 50% of the tests that are positive are accurate. And then for negative predictive value, we've got 787 negative tests. 757 of those are true. So we divide 757 by 787, and we get 96.1. And so in this population, with disease a little bit higher than what we dealt with on the first scenario, we have a higher positive predictive value. We'll put a little more belief into that if we get a positive test. But we have a little bit of a lower, not by much, but a little bit of a lower negative predictive value. Still pretty good, but a little bit lower. So this is just recapping the difference between what we found with that. We had a 1% prevalence, and we only had a 6% positive predictive value. We had a 15% prevalence, and then it bumps to a 56% positive predictive value. So that was just an example of how prevalence affects positive and negative predictive value. With my students, we put that into to put it into a real world situation. We are in Mississippi, and so heartworms are prevalent here. And so we talk about with my students that if we had a dog that came in here and wasn't on heartworm prevention, and it tested positive for heartworms, we probably wouldn't be very surprised about that. If that animal came in lethargic and had a exercise intolerance and it tested positive, we sure wouldn't be very suspicious of that. We would probably agree with that. But if we were testing an animal in some part of the United States that doesn't have heartworms or has a very low incidence of heartworms, and that animal came in, we would, if it was looking healthy and we tested it for heartworms and it was positive, we might not believe that. We might think, what do we need to do to be sure about that? If it came in with the same sick dog came in and now it's got some clinical signs, we have a little bit more belief in that, but we still might think, what else could be causing this? Because heartworms are just not that big a thing here. So we might not believe a positive test. But if we had that same sick dog in somewhere that didn't have heartworms with pendulous abdomen, exercise intolerance, lethargy, and we did a heartworm test, and it was negative, we probably would just think we needed to move on to something else. It probably wouldn't surprise us too much for it to be negative in an area that doesn't have heartworms. Okay, so we are going to continue with this, assuming that the prevalence of FELV in healthy cats is about 3%. And so people that are smarter than me can come up with spreadsheets like this that can give you your positive and negative predictive value based on your test performance, your sensitivity and specificity of that test, and the prevalence of the disease. So in this case, our pretest probability is the prevalence of the disease, which is we're working with 3%. So for a positive test, we have a 45.1 positive predictive value and a 99.8 negative predictive value. So if a healthy cat, again, we're dealing with healthy animals, if it comes in and we test it and it's negative, we're not probably going to give it a second thought. We're going to believe that negative test. If it tests positive, well, now there's a little bit more of a chance that it has FELV. We might want to follow that up or chase that down a little bit. But that's only increased our index of suspicion by 45%, because we know that of all the positive tests, only 45% of them are actually correctly identifying those animals. This is what I just showed you in chart form for people that are visual. So we have a 3% pretest probability, a 3% incidence of the disease. And if we follow that up our chart, we see that we have about a 50% positive predictive value and almost 100% negative predictive value. So same thing I just showed you. The negative predictive value of this is really, really high because our disease is really, really low, right? Our incidence of disease is really low. And so we're pretty confident when we get a negative test. And so for positive predictive value, it does increase our index of suspicion. But what this tells us is that more than half of the cats that test positive still don't have the disease. We're still incorrectly classifying half of those. All right. So, and as we move up our pretest probability, up our incidence of disease, our positive predictive value goes up, because the more prevalent the disease is, the more likely we are to see a positive test and believe that. And our negative predictive value then goes down, because thank goodness there's not 100% FELV in the population, but if there was and we got a negative test, we would believe it not at all. All right, so we might say we have this really cute kitten and this really cute 10-year-old girl, and I have to tell her that her kitten is positive for FELV. So we might say, well, let's just back that up with another test. And so what you have just decided to do is serial testing. And so this is when there are 2 tests or more, but usually 2, that are conducted sequentially. So you run a test, and the animals that test positive on the first test are then tested again. You only test the animals that are positive on the first test, and they have to be positive on the second test to be considered positive overall. So in a sense, that animal has to prove to us through 2 tests that it has the disease. So it has to test positive the first time. If we test it again and it's negative, we say, whoa, we got out of that one, it's actually negative. If we test it again and it's positive, then we consider that animal positive. And so this is a really good way to rule in a disease. And we use this when a false positive is more costly than a false negative, which is for this particular kitten where we are, or when it's a low prevalence. Okay, so what does that mean? When we do serial testing, we decrease our sensitivity and we increase our specificity. And if you could answer me, I would ask you why that is, and I would pause and let you answer that. But since you can't, I'm going to tell you that it decreases our sensitivity because now we have given tests for we've given 2 times for it to be falsely negative, right? Remember, sensitivity is animals that have the disease. It decreases that because if they're negative, now we've given them 2 chances to test falsely negative. If they test falsely negative on the first, we're never going to know it. We're going to assume they're negative. We're going to not retest them. And so that there would be a false positive on that test. If you have an animal that tests positive on the first test, well, they still have a chance to test falsely positive, right? Because they've tested, falsely negative, sorry. They've tested positive. We test them again. And if they test falsely negative, we're still going to say, okay, good, they don't have the disease. So it increases our specificity because we're not going to get as many false positives, right? They would have to have 2 false positives for us to have an overall false positive for that animal, which is pretty unlikely. But it's, it's pretty believable that they might have a false negative on one of those. But it's harder for them to have a false positive because they have to do it twice. For the same reasons, it decreases the predictive value of a negative test, but it increases the predictive value of a positive test. Because if we consider this overall, they've got to go through 2 different tests before we'll consider them positive, then we can be pretty sure that's positive. We feel pretty good about our positive answer. All right. So we're going to work with our kitten a little bit more now. So we're going to say our first test, we have a 3% prevalence of disease. Our first test is going to be 97% sensitive and 97.5% specific. All right, so here we go. This is our test number 1 for an example of serial testing with FELV with prevalence of 3% in the population. So we have 1,000 cats. 3% of that is 30. So we are all knowing, and we know that 30 animals of this 1,000 have the disease. We therefore know that 970 of those animals don't have the disease. And we know that our sensitivity is 93%. So of our 30 sick animals, we're going to correctly find 28 of those. Our specificity is 96.5%. So of our 970 non-diseased animals, we're going to find 936 of those, which means that we have 2 animals that are diseased, but we don't know it. And we have 34 animals that are healthy, but we think they're diseased. And so problems with both of this, right? Both of these things have consequences. If you're a shelter and you're trying to get FELV out of your population, well, having 2 animals that go into your population that are diseased and you don't know it makes that pretty impossible. And if you're a shelter and you're making some decisions based on positive tests, you may be making euthanasia decisions, you may be making a decision to put a cat that's got FELV in a FELV room or FELV foster care or something like that. But if that animal doesn't have the disease and you euthanize it, that's awful because of, you think it has a disease. Or if you think it has the disease and you put it in a room with other cats that do have the disease, well, then it's definitely going to end up with the disease. So both of those have consequences. We are worried about our kitten. We're wondering if it's in this situation, right? We are wondering, this is a mistake we don't want to make. We do not want to tell a 10-year-old little girl that her very healthy kitten has this disease when it doesn't. So we're going to back this up with a second test. All right, remember, we're serial testing, and so we are only interested in these 62 that tested positive. By the way, we could figure out your positive predictive value, 28 over 62, that's 45%, which is a lot of cats that we can't trust the test with, right? A lot of positive tests that we can't trust. So it increases our index of suspicion by 45%, but still a lot of chance that we can be wrong. So we're going to test those 62 cats again. Our negative predictive value is 99.7. We feel pretty good about that. We've already talked about, we may have released 2 back into the population, but that's a problem for another day, I guess. We're just worried about this little kitten right now. All right. For serial testing, we are only going to worry about these 62 animals. So that becomes our population that we're testing. We're going to take the 28 true positives from that first test and assume that they have the disease. And this is, again, a case where we're all knowing, so that happens a lot in this presentation. And then if we have 28 cats that do have the disease, we have 34 cats that don't have the disease. We have a test with a higher sensitivity and specificity now. So we have a sensitivity of 97%, which means we can correctly identify of the diseased animals. We're going to correctly identify 27 of them. And we have a specificity of 97.5. So of the non-diseased animals, we're going to correctly identify 33 of them. But we still lost one. We still have one more. So this would be our we've increased the chances now for them to have a false negative. But we have really meaningfully dropped the number of animals that we think have the disease when they don't. You can figure out the overall sensitivity and specificity for this. So here's the two tests side by side for comparison. Our net sensitivity here is 90% because 30 animals were positive. We found 27 of them. Remember, they have to test positive twice to be considered. So 27 of 30 is 90%. You can also do that with the sensitivity and the specificity, and that should be the sensitivity that you expect from this test. The net specificity is a little bit more complicated. 936 animals tested negative, so they were correct. We're going to keep them. An additional 33 tested negative, and so now they fall into our negative category because they didn't prove that they're positive. So 969 animals divided by 970, which were the total that didn't have the disease, is 99.8% specificity. Net specificity overall. So we've increased our specificity. Okay, so should a shelter then test healthy cats for FELV or FIV? Mississippi State actually is working through a project about this, and we've done some prevalence studies with FELV in shelters. And so what we've been dealing with, what I've told you so far, is that we've used a 3% prevalence, and that comes from some numbers from the past that we've thought were the correct prevalence. But when we did this, we tested 184 cats. We found 3 that were positive for FELV. We found 6 that were positive for FIV. Those were all different cats. So we found 9 animals that were sick. But if you use the apparent prevalence and you take into consideration the performance of the test, the expected performance of the test, what we really end up with is a negative number. And these confidence intervals, of course, cross 0, cross 1, but we really get our highest level of confidence in this is about 1%. And so what we think is that among healthy cats, this is not sick cats, this is only cats that come into the shelter healthy. They may have fleas or ear mites or something like that, but they don't have upper respiratory disease. They're not lethargic. They don't have diarrhea. They're all pretty healthy. And so for that population of animals, we think the prevalence might actually be a whole lot lower than that. And so now, if you think back to those 2 animals, if we're trying to get it out of our population, and you think back to those 2 animals that were negative, and the animals that were we sent back into the population, we're not changing our population a whole much from this 1% prevalence that it would be if we didn't test any of the cats. On the other hand, there were quite a few that were positive, and we're probably calling a lot of cats positive that don't have the disease. All right. Another way you can test, you can do multiple testings, is parallel testing. And this is where we conduct 2 or more tests at the same time or about the same time. And the animals are considered infected if they're positive to either of the tests. So this is kind of opposite of serial testing, where they had to prove to us that they're sick. Now we're asking these animals to prove to us that they're healthy. Because if they test positive at any point, we're going to say they're positive for the disease. And we can use this to rule out a disease. And we'll use this when a false negative is more costly than a false positive. So there are testing situations when, especially in cattle, when you're, an example of this would be testing for some disease that you don't want to get into the population when you're buying or selling or leasing bulls or cows or whatever. If you're bringing an animal into your population, or if you are responsible for sending an animal out into population that you're deeming to be healthy, then a false negative would be a big deal. And so what does this mean for our test performance? So this is pretty much exactly opposite of serial testing, which is what we want. We have an increased sensitivity this time because we have fewer false negatives. We've given them, they have to have 2 false negatives to be considered negative overall. We've given them decreased specificity because we're going to get more false positives, right? If they test positive on any test that we run, the first test or the second test or however many we run, if we find any positives, we're going to call them positive. So that increases the predictive value of a negative test. We've run several tests, they're all negative. So we can be pretty sure that this animal is negative for disease, but it's going to decrease our predictive value of a positive test, right? Because the minute they come up with a positive, whether or not it's true, we're going to consider that animal positive. All right, so let's look at parallel testing. We've got our population of 1,000 animals. We have a 90% prevalence here. So this is why we would use serial testing, right? We're going to be kind of surprised if we don't find this disease in this population. And so before we say we've got an animal that's free of disease among a population where that disease is pretty prevalent, we want to be sure that we've got it right. So 900 of our 1,000 animals have the disease. Our sensitivity is 80%, and so we're going to find 720 diseased animals. We're going to correctly identify 720 diseased animals. We're going to correctly identify 60 healthy animals or disease-free animals. We're going to miss a lot of both, right? We're going to miss 180 animals that were diseased, and we're going to miss 40 animals that didn't have the disease, but we're going to say that they do. Okay, so this is test 2. Remember, we're running this at the same time, so we're using that same population. In serial testing, we were only interested in the positives, but for parallel testing, we run the test on everybody. So our same population of 1,000, we have 900 animals that have the disease. We found 90% of those, 810. We found 90% of the healthy animals, of 100 healthy animals, so that's 90. All right, so if they're positive on either one of these tests, they're positive. Now, when you're looking at overall net sensitivity, it gets kind of complicated with this because we can assume, probably pretty accurately, that a lot of the ones that tested positive on this one, we're also going to test positive on that one. And we can't just add those numbers up then, because we would be counting some of those animals twice. We would end up with more positive animals than we had in our population, which doesn't really work. So we're going to figure out, what do we think the crossover is? So we have 720 animals here. We had a sensitivity in our second test of 90. So if we take that 720 and we think we probably found 90% of those, that's going to be 648 that we probably would have found with this test. So there were, if you subtract that from 720, there were 72 tests that were positive here, that didn't make the positive here. 810 minus our 648 is 162. So there were 162 tests that we found positive on our second test that we can assume didn't show up on our first one. And if we add all of those together, then if we add all of those together, then we get 882 total. divided by 900 that had the disease, and our net sensitivity then is 98%. So we've really increased that sensitivity over what either of those tests could do on their own. Specificity is a little bit easier. Our 60%, remember, if they're positive, if they're negative, they have to be negative on both. And so there's only 60 animals that could have possibly happened to, but our specificity is 90%. So we're not going to even catch all of these same 60. So we would assume that we have about 54% specificity here. All right, so parallel testing drives our sensitivity up and drives our specificity down because it gives us more chances for a false positive. Okay, so take-home message of this is that I want you to think more in terms of predictive value. It's pretty easy to think about when you're thinking about a diagnostic test. Well, what's the sensitivity and specificity? But a more accurate way to think about that is what's the predictive value, because that takes into account the performance of the test, the prevalence of that disease in our population. And so that is a better thing to think about when you're figuring out whether or not you can believe your test. We're going to use sensitive tests to minimize false negatives. We're going to use specific tests to minimize false positives. When we serial test, we increase the specificity, but we decrease the sensitivity. When we serial test, we increase the positive predictive value, but we decrease the negative predictive value. And all of that is, I gotta quit using my mouse. Okay, all of that is opposite in parallel testing when we increase the sensitivity, decrease the specificity, and increase the negative predictive value, but decrease the positive predictive value. Okay, but a lot of us think in terms of populations, right? So we were talking about this little kitten. What do we tell the mom and the little girl? And probably we decided that we need to follow that up with another test, right? But what about most of us that think in herd health? How do you figure out how many animals you've got to test to have the best probability of detecting a disease within your herd? Herd level sensitivity is the probability that a herd with a disease will be correctly classified with that disease. And herd level specificity is the probability that a herd that doesn't have the disease will be classified as not having the disease. Herd level sensitivity and herd level specificity are influenced by the sensitivity and the specificity of the tests that we use, the disease prevalence in the herd, the number of reactors. So how many do we have to get that are positive before we consider that herd positive? So if we get one positive test, does it mark the whole herd as positive, or do we have to see it more than once? The size of the herd, and then the number of animals that we test in that herd. So we're assuming here that we are sampling to detect a disease. So our herd level sensitivity is the probability that we're going to find that disease or that infection that's in the herd. We are going to use larger sample sizes to increase our herd sensitivity. So we'll say here we have a test sensitivity of 90% and a specificity of 97%. Now this is individual. And then the prevalence in the herd, the actual prevalence is 0.1. We have a herd size of 400 and 0.1 of that is affected. And so what we can see is that our herd level sensitivity is pretty high, right? We're looking for animals that have the disease. As soon as we find one of all the animals that we're testing, as soon as we find one that has the disease, well, we're going to classify that whole herd as positive. On the other hand, our specificity pretty quickly gets pretty low because the more animals we test, the more chances we have to have a false positive, right? So specificity would be dealing with animals that don't have the disease. How likely are we to see a false positive that would make us incorrectly label that herd as having that disease? So herd level predictive value and herd level negative predictive value is the possibility that the herd is classified correctly, right? So the probability that a herd classified as disease really does actually have that disease. And the negative predictive value is that the probability that that herd classified as not disease really is truly and free of that disease. Okay, so this is what I just showed you a minute ago. And what I want you to see here is this is our herd positive predictive value. It's pretty low here, right? And that's for the same reason, because if we are trying to rule in a disease, if we're trying to make sure if this herd has a disease, we find it, the minute we have a positive, we're going to call the herd positive. And so that's pretty low because we have plenty of time, plenty of chances to have a false positive. On the other hand, our negative predictive value, our herd level negative predictive value, is pretty high because chances of every single one of these being false negatives are low. So if we really can test as many animals as we say we need to test and not find a positive, we can feel pretty good about that. All right. So when multiple animals are being tested to determine the infectious status, you really want the test specificity to be as high as it possibly can be. And the probability here, the problem that we're dealing with is that if a herd is classified falsely positive. So we can do this with serial testing as well, right? That comes up a lot in herd level medicine. So we can screen the herd by an inexpensive screening test. We can screen everybody. And then if somebody comes out positive, we will confirm those with a highly specific test, right? So if they're positive, we want to confirm it with a test that's highly specific, which means a test that's going to have a low rate of false positives. You can change the cutoff point. So you can say, you can change how many animals you have to see positive before your herd is positive, or if you're looking at titers or something like that, you can change the cutoff point of what is positive, or you can require more reactors. In this, we are sacrificing sensitivity to increase the specificity. So the more animals we test, the more likely we are to get a false positive. But we're not going to be as likely to get a whole herd of false negatives. Okay, so now we've given up a little bit of sensitivity, right? But we have increased our specificity in this test. And so now our herd level predictive value is much higher. All right, and real quick, and then we'll answer any questions. This is just an example, right, of when you would use this. So many of you are familiar with bovine tuberculosis testing methods, and what we know is that you do a pretty easy, non-invasive, cheap screening test, and when that comes back positive, if that comes back positive, raises the stakes a little bit. But before you really get excited about having a tuberculosis positive test, you're going to run another test on that, right? And make sure that it's positive before you find it, before you claim that herd has tuberculosis. Okay, and I think that is all I have. And so I have time for a few questions, I think.
And with that, we can move into question and answers. Well, before I do that, I do want to point out there's a few comments in the chat session. One of our colleagues posted a APHIS website. It's a outbreak surveillance toolbox. And then another one of our colleagues mentioned that he had a former graduate student created a spreadsheet to perform calculations. And I'll touch base with him afterwards, and maybe I can include that spreadsheet in the email message that I send continuing education certificates out to. With that, I'll go to the question and answer box. We have one question, and And it's Dr. Woodruff. Can you provide some overall examples of where you might use serial testing versus parallel testing? The individual asking the question is thinking serial testing for highly valuable individual animals and parallel testing for highly communicable diseases in herds.
Exactly right. So um, if you have a very expensive bull and it comes back with any kind of positive test, really, before you call that bull or tell those owners that they're going to have to, that they can't sell the bull or whatever, you're going to want to make sure that that's correct. And so that would be serial testing, because you get a positive test and you'd think, I'm not sure. And if before I get everybody all excited, I want to be very sure that I'm correct, you would run that serial test. On the flip side, if you had a disease that either you expect to be there, so you're going to be surprised if you don't find it, or if you send an animal out that's positive for that disease and it's going to, come back to on, a cattleman's reputation, or it's going to introduce disease where you really don't want to introduce disease, then if it tests negative, you're going to want to be really, really sure that that animal is negative. So you're going to give it one more chance to tell you that it has the disease before you say, okay, well, it told me twice that it didn't have the disease, so now I believe it.
All right. The next question is, when serial testing, are you using the same test?
Oh, that's a good question. No, you will. Generally, you would use a cheaper, less invasive test for the first one, right? And then if it tested positive and you wanted to back that up, well, I guess backing it up isn't really the right thing, but if you wanted to test that again, you would use a test that might cost a little bit more, or might be a little bit more invasive, or for whatever reason wasn't your first good go-to test. But you don't want to use the same test, because if you're looking at a false positive, whatever was there that cross-reacted the first time is probably going to be there the second time. And so you don't want to give it that chance. So you want to run a completely different test and make sure you get positives on both of those tests before you call that animal positive.
All right. A third question comes in, or came in. At the herd level, can you provide some thoughts on frequency of testing in a naive population? The positive predicted value is low when the prevalence is low, but as the disease progresses, if true infection, the positive predictive value will increase. Any thoughts on frequency to improve early detection?
I think it depends on your herd, right? If you've got a closed herd and a low prevalence of disease, and you have very little reason to think that that disease is there, you're not going to want to just test just to be sure, because the more times you test, the more likely you are to get a false positive. If it's a disease that doesn't show up until later, has a long incubation period or something like that, you may want to retest at different intervals. But what you're going to want to take into account, it's hard. I can't give you a testing interval, because it depends on the test. It depends on the disease that you're worried about. You would take into account the incubation period of that disease, how long it takes to show up in your herd. You might take into account, like, you might do it before you're breeding cattle or something like that. And so you're really going to want to tailor that to the disease and to what's going on in your herd.
But I'll draw people's attention to the chat. There have been several comments about other websites with tools to use for these calculations. What I will do is I will take these websites, and when I send out the email for the CE certificates, I'll include these links in that email. Another question did come in while I was speaking. How do you find out a test sensitivity, specificity, or positive predictive value or predictive negative value?
So generally, the sensitivity, the specificity and sensitivity, the sensitivity and specificity should be supplied to you. Like, that should be information that you can get from the company that sells you the test. They should be able to tell you what the performance of their test is. You have to keep in mind how that might have worked, that sometimes lab conditions or testing conditions are different than real world conditions, but that should be information that they can give you. For the positive and negative predictive value, again, I keep saying it depends on the disease, but remember, prevalence plays a huge part in that. And so you can find out the positive predictive value by thinking about how that's working in the population. If you know the sensitivity and specificity of a disease, and then you know if that disease is highly prevalent or not very prevalent in your around you, then you will be able to figure out the positive and negative predictive value. If it's a prevalent disease, then you're probably going to have a higher positive predictive value. If that disease is not very prevalent, probably going to have a lower predictive value. So you can find those things, but it includes a little bit of math.
Okay, well, that completes our questions, and I want to thank Dr. Woodruff for an excellent presentation, a wonderful review on some basic fundamentals of epidemiology. I'll turn it over to Dr. Stephen Castle, the chair of our Continuing Education Committee, to see if he has any final comments.
No, just a great presentation. Look forward to the next couple of months when we've got a lot of good CE webinars coming up. Kimberly, thanks for the review. I was taking lots of notes because I remember spin and spout, but you brought it back up to the top of my mind. So thank you very much.
Thanks for having me.
As Dr. Castle said, we've got a lineup for the next few months of webinars. So keep an eye out for invitations. And also, if you are interested in possibly presenting during our webinar series, please email me at admin@acvpm.org, or you can also go on to the ACVPM website under the Continuing Education tab. There's information of how to volunteer to be a speaker for our webinars. So once again, Dr. Woodruff, thank you very much. And I want to wish everyone a very pleasant afternoon or evening, and keep an eye out for future invitations. Thanks much.